So I'm really happy to be talking today about the Partnering to Transform Health Outcomes with Persons with Intellectual and Developmental Disabilities program. This is a program that was funded by the Administration for Community Living under a workforce development grant in 2020. And so we're now 3.25 years in, and we're in what we call phase 3. And we're mentioning that we're using the collective impact model as an organizing framework for the program, which has been quite useful for us. I've sort of wanted to promote also the collective impact model. So I guess move the slide.
Okay, sorry. Let me just get myself in order. Okay.
And there are 5 core partner institutions who are involved with this program. It's Rush University, we're the lead institution. There's the Golisano Institute for Developmental Disability Nursing, which is at St. John Fisher University.
I'm in love with my husband.
The Department on Disability and Human Development at UIC, University of Minnesota, the Institute on Community Integration, and Villanova University, Suzanne Smeltzer. I'm not sure she's on the meeting. She's there. And it's notable that the UIC and Minnesota are part of USEDS. So like I said, context, this is a program funded by the Administration for Community Living. It was a workforce development grant under the notion of closing the gap. Like I said, it's led by a consortium of 5 institutions. And their aim, what we said the aim of this program was to improve the education of healthcare professional students is the main focus, although professionals in general would not be incorrect, in the health and healthcare of persons with intellectual and developmental disabilities. So next slide. So as we know, the general problem is there's a lack of education of healthcare professionals in the health and healthcare of people with intellectual disabilities. There are no, outside of dentistry, maybe speech language, there's no requirements or standards. There's just systemic ableism in the healthcare system, pretty pervasive. Like, often I go. So what we decided when we looked at what we thought we could do, we decided to develop a suite of materials, interprofessional materials at our 5 core partner institutions that could be implemented at a variety of institutions basically now. So in the absence of standards, in the absence of even a lot of the universities which we might be working with may not have standards or materials or any public statements on the issues, we intended to develop things that people could take on now in the general overall context. And we did certainly consider the shift towards interprofessional education that's going on in healthcare, and that people with intellectual and developmental disabilities often need a team in their healthcare. So the materials we're developing would be interprofessional. So next slide. So I don't know if people are familiar with the collective impact model. Came out of Stanford. It looks at, in the collective impact model, you get people and organizations from a variety of viewpoints, variety of roles, and the point is to take on a common problem that involves some sort of system change. It generally involves community members, organizations, and institutions which come together. They definitely come from different perspectives. They may not all, in fact, you don't want them to have the same viewpoint getting started. They come from different perspectives. And part of the point of collective impact is you learn together to better identify underlying mechanisms of problems and create an understanding needed for change, realizing that when you're talking about complex problems that require a system change, there's not like one thing that's going to change it. It's usually many different moving parts that will change, and try to integrate actions to achieve change. There are 5 basic tenets to collective impact. So change slides. And I'm going to try to, I like to talk fast, and I grew up in the South. I don't know why, but anyway. So collective impact model, as we said, you're trying to look at complex problem that involves system change. And certainly the lack of education of healthcare professionals and students in disabilities and intellectual disabilities. It's an ongoing problem. It's been identified for many years, and our experience is it's complex. And typically these problems have multiple root causes, unclear solutions, and they need action from multiple stakeholders who may not agree either on the nature of the problem or how it should be addressed. And using collective impact requires learning by doing. And they talk about using a complexity lens and an adaptive approach when you're addressing collective impact. So next slide. So as I said, in the collective impact model, the community members and organizations, they come together, they come from different perspectives. I think we went backwards once.
Oh, did we go back?
Yeah, I think I said that one. So, all right.
There we go.
So
Forward.
I think the backwards one.
Backwards one.
Yeah.
Okay.
So these are the 5 tenets. You have to develop a shared agenda. And for us, part of collective impact models, you have like leadership, and then you have what they call action networks. So we have a steering committee, we have an advocate committee, and we have 3 action networks, one of which is a communication action network. We have a measurement action network, and we have what we call education, practice, and policy action network. So in the 5 tenets, one tenet is you have to work towards having a shared agenda. So for us, the steering committee and the advocate committee have overall responsibility. We are trying to build it, at least we're working towards the steering committee and the advocate committee together lead the program. Then the continuous communication, I think in our world, we kind of understand that you have to keep on talking to each other and come to agreements and figure out what you're doing. And we have a communication action network as well, which takes accountability for practices that improve our understanding of the problem. Then shared measurement is one of the tenets of collective impact. And we have a measurement action network that takes accountability for that. Activities. So we have our education, practice, and policy action network, take accountability for that. The 5th tenet being backbone support. Rush University is the lead institution, but each consortium partner has specific responsibilities. And I'll note that the Communication Action Network and we have a website called IDD Health Equity. We also have a social media presence. So IDD Health Equity on LinkedIn and some iteration of that term on Facebook, X, and I think we have now one of the other ones. I can't remember, not TikTok, Instagram. And maybe I'll digress a bit there. I would say we have the great sort of honor and its assistance that we got a grant from the WITH Foundation early on in the grant to hire a content strategist. So that content strategist is a full-time position or close to full-time, half paid for through the original grant and half paid through the WITH Foundation. And it's, let me tell you, that is so fabulous. It's just like fabulous to have somebody who really thinks about, okay, you got a message. Now, how are we going to get that message out there? And how are we going to promote it? And she's very good at that. So, she's very good at the website, what the social media strategy and so forth should be. And so I would say, that a lot of the responsibility for the backbone support for those efforts comes out of St. John Fisher. Next slide. So participatory action. So we also said we are, while we're Collective impact is our organizing framework. We're using participatory action as a theoretical model. It emphasizes participation and action by members of affected communities. And then, of course, with us, with particular emphasis on people with intellectual and developmental disabilities. And it certainly fits with the collective impact model, which also says you have to have people in organizations, et cetera, affected by the issue participating. So we are also using co-production as a related concept. So if you look at literature on co-production, it also says you have to involve people from impacted communities or affected communities, and that's an ethical issue in healthcare, that it would transcend the traditional dichotomy between knowledge and program developers and users. We're trying to bring them more as an integrated whole. And it certainly involves building collaboration in the production and use of programs from the start of the process. So I would say that one of the things that we found as we proceeded in this grant, when we established our infrastructure in the first year, we had our 3 action networks and a steering committee, and we had advocates on every one of those committees, and more than one. But somewhere about a year in, we said we still weren't satisfied with the voice of, working with the voice of people with intellectual and developmental disabilities. So we decided to develop a separate advocate advisory committee as another place to give voice, and to give and to make it advice for the developers of the grant. So in about a year in, we formed a separate advocate committee to co-lead the program. Next slide. So then I'll talk a little bit about, I'm hoping this is interesting, how we actually went about organizing it. So phase 1, what we call phase 1, and that was roughly the first year of the grant. We focused on developing our infrastructure, structures, and processes. So considering building the common understanding and mutual agenda, we organized a steering committee and 3 action networks. And I'd say probably between those things, where there's probably about, I have to get the last count, but about 50 people who one way or the other are participating. And that was all about, you have to have we have to have infrastructure to run this kind of program. And it's all also then trying to bring in through those action networks and the voices of different people. So the next slide. Also, in the first year, as part of building common agenda, key personnel, we organized training from FSG, Imagining Social Change. Their thing is collective impact model. We had 2 days of training on collective impact. I certainly remember the dates because the first day of training was January 6th, 2021, where then everybody's cell phones were blowing up. And then January 13th. So we had the insurrection and then the impeachment that went on at the same time. So that was we did 2 half days of training for our for the key personnel, and then based on we also worked with the National Center for Interprofessional Practice and Education and training from them on interprofessional practice and education. We also set up discussion sessions for key personnel on addressing structural racism, because we wanted to deal with intersectionality. So we looked at Black Lives Matter, a commentary on racism and public health, the health disparities in adults with IDD living in the United States. That's the Susan Haverkamp, one of their articles, and then the health advocacy training from UIC, their health advocacy program. So trying to get a common understanding of, the interaction between intellectual disability and structural racism as part of this. So this was trying to develop amongst us some common understanding of, I guess, background of what we were trying to do. So next slide. So as I said, for mutually reinforcing activities, we did organize 3 action networks with multiple stakeholders, the 3 that I mentioned, and all of those are overseen by the steering committee and advocate advisory committee. Next slide. So I should say the steering committee meets quarterly. And over, it reports on what's the ongoing work, makes suggestions. We, modify what, it's very useful. It's usually very useful, intense discussions about how to proceed. There's an advocate advisory committee. It meets about 10 times a year. And typically their meetings consist of presentations from the 3 action networks about what they're up to, and there's recommendations. And we've had presentations from others who are doing similar things or thinking of doing similar things about their programs, and where the members of the advisory committee can give their advice. And I think they find it very useful to have a broader view of what's sort of going on out in the world, so to speak, and about what kind of advice they want to give. And then the 3 action networks, usually also their meetings often have presentations from others in the field in relevant areas. So for instance, one of the last presentations at the Measurement Action Network was on how, was from Dr. Van Pembroke at Rush, who talked about how they're measuring ableism, structural ableism. There's an ableism scale, and some concepts and how this gets measured. And I think in the current context where NIH is now talking about ableism, there were a number of people who came to that presentation or who have opened it up. It's now up on our website. So these give us also then some broader perspective, that's both our grant itself, but what's going on out there in the broader world that we should be taking account of as we're working on our program. And as I mentioned, with the WITH Foundation funding, we have a content strategist who manages the website and coordinates social media, and all of that was thought of how to emphasize the participation of people with intellectual and developmental disabilities. So, for example, there's a series of short videos that are on our website that are people with intellectual disabilities talking about why health is important to them. So I think they're interesting anyway. There's some interesting ones. So that's sort of, we established these structures. It's not like we're not still working on establishing them, but this was a good bit of the work in the first year. Next slide. So as I said, there's a backbone infrastructure. So it's Rush University. We take the team there, coordinate and schedule meetings. There's a monthly newsletter that comes out. There's a lot of correspondence. I would note St. John Fisher again, that there's the content strategy over the site of the website that goes on there. So, and a lot of collaboration on the newsletter. Right now, I think we have 257 that get the newsletter every month. So next slide. So phase 2, which was roughly years 2 and 3, we worked on developing a suite of curriculum materials and practice experiences. As I said, with the idea of having a range of materials that could be implemented in existing situations. So if what you could implement is some didactic material only, we have it. If you are looking for some sort of clinical experience, we've got that, and also simulation experiences, we have those things. So there's a range of materials that you can do something with, so basically right now. Part of our thinking, and I think there was some discussion of this, but what is the grassroots up thinking? We're realizing, I know in medicine, nursing, there's been ongoing efforts to get the official bodies. I'm more familiar with those efforts to do something about disability anyway, and we know where that's going. I keep thinking that sometimes it looks like maybe something's going to happen. I'm hoping it will. We're not willing to wait on them, but I think part of doing this kind of work puts more pressure from the grassroots. So next slide. So these are some of the specific programs we've developed. So one is the Special Olympics Inclusive Health Fundamentals course, which is largely funded through the CDC to Special Olympics. There was basically there was some funding from our grant for pilot work and some other, and some specific things to do with it. So it was developed by the Golisano Institute for Developmental Disability Nursing in collaboration with the University of Minnesota. It's a 5-module program. It's free. I believe did I put the website, I believe, is ipe.specialolympics.org, but it's a 5-module program. It can be used as part of a credit-bearing course. I'm not sure if Rebecca is on, but you're working with it as part of a course. It could be part of a service learning program. It could be integrated one or more modules into an existing course. It was piloted at 6 institutions in spring and summer of last year. At St. John Fisher, University of Minnesota, and Rush were part of the 6. And that was in the spring and summer. And there were more than 450 students who completed the training at that time. And then that course has been upgraded. It's really upgraded quite a bit. And it's now available generally. Last I heard, it was like 40 some institutions were working with it or plan to work with it. And then it's also being used for training at the CDC and a couple of other places. And it's free. And I think my understanding is they may be working on getting CEs for it, but that's not available yet. Next slide. I should say, so it could be of that course, like it could be part of an ongoing course. At Rush, we've put it up in our learning management system, which is Canvas. Students go directly to the website, to the Special Olympics website to take the modules, but we have a little, like a reflection question after each module that we take one of the reflection questions that are in the modules, and students have to answer one of them. And if they do all that, and they take all 5, we give them a micro credential for completing it. So it can also be used that way. So at Rush, what we call it an advanced interprofessional service learning experience. And and we are working in collaboration with a community-based organization that provides comprehensive services for people with IDD who are on the south and west sides of Chicago. So say their clientele is overwhelmingly African American. And we based it on the social model of disability, specifically addressing intersectionality. So for us, for this particular course, it's for students who have completed our mandatory 2-trimester IPE program. They have to have done that before they come in. And it's voluntary, but service learning is part of the institution, and all the programs at Rush, all the different health, and we're only a health professional institution. We don't have any, French history, any of that. It's all healthcare professions. Every single program has requirements either for professional development, for service learning, or for direct hours in order to graduate. So we recruit students who have already taken this previous course, and they work in interprofessional teams with what we call community health mentors. They are service users with residential service users who have intellectual disabilities at this agency, with a staff person who supports them. And they work over 3 telehealth sessions to develop wellness goals with action plans. And I should say it's a 10-week program, and in it, there's very short modules each week that cover such issues as social model of disability, intersectionality, bias among healthcare providers, advocacy, so forth, health promotion in the context of chronic conditions, and so on. And there's students have reflection questions for evaluation. So we have now run this program for 4 trimesters. So we have so far a total of 73 students from 10 disciplines who partnered with a total of 26 community health mentors in completing these, in developing these action wellness goals with action plans. And we'll be starting up our 5th time next week. And we are planning in Illinois, the health risk screening tool is an instrument that looks at health risk in people with intellectual disabilities, and it's mandated in Illinois. I think there's 7 states that mandate it. Illinois is one of them, and it has to be filled out every year for people in residential services. So we're planning to look at, are we getting anything different with the people? We now have a sample size. We could look and see if there's any change in the HRST scores. We kind of don't think so. They're probably too, might say gross of a measure to pick up slight differences that might come from our program, but we're going to look at it. And for these students, and we give them a micro credential that has 15 professional development hours that include 8 service learning hours. And like, for instance, we looked around. So respiratory therapy, those students have to have 8 service learning hours per term. There's another that has to have 6. And then the physician assistants have to have 12 before they graduate. So we're trying to give something that is, these students have to have in order to graduate, even though we're not giving them a credit. So I guess next slide. So just to say say a little more about the service learning program, since we're talking to some people about taking it on. In our mind, it could be condensed. I mean, we have it as 10 weeks because that's fairly convenient for our time frame. So we start like the 2nd week of the term and we finish before people get into finals. But it's spread out enough. So there's like, when we start the telehealth sessions, there's 2 weeks between them. But it could be condensed. It could be, it runs, we figure students, it's about an average of an hour and a half a week over the 15 weeks, but it could be part of a larger program and used as just a piece of a larger program. We think it's fairly flexible. And even like the first module, which has a wellness interview and you come up with an wellness goal and an action plan, to me, it could be done at like a health fair in a booth, and that's all you do. You don't have a follow-up, but it could be utilized in a number of ways. So the other thing is simulation experiences that are at Villanova and at the University of Illinois at Chicago. And so these were, the first round were implemented last spring, and both had people with intellectual and developmental disabilities working as standardized patients. At UIC, standardized patients were recruited through the Department on Disability and Human Development co-op project, which was a workforce, trying to get people into the workforce so there was a training program. So we were recruiting people who were trained to be standardized patients. In my understanding, some of them have already been hired elsewhere to do this besides this program. So it's meant to be also job training with that grant. In that first term, there were more than 80 medical, dental, and nursing students who participated in the simulation training. This program has been expanded to Temple University, part of it because somebody who was at UIC became the director of simulation at Temple, or at least nursing sim lab. And then there's also, they have information on how they conducted the training for the standardized patients. They did work with theater coaches in the training, because you're trying to, train somebody to act like they're having a heart attack, or to act like what in this case, I think they were more like acting like they were having a dental abscess, but what might you act like if you got a major dental problem? And then, so there's materials on how was the training conducted, as well as there's the scenarios that were used. And I know they're working these up to be in, as they are working up, I think, to do some of it as videos that would be case studies. But the materials would be available. Also at Villanova, along with St. Joseph's University in Pittsburgh, they also had a program that had more than 80 students in that term. And I think they are will be having another this coming, this term now. They had people with intellectual disabilities and their caregivers acted as standardized patients with a caregiver. And they had an advisory committee of people with intellectual disabilities, family members, and disability advocates who helped to develop the scenarios and so forth. And they are working with the National League of Nursing to upgrade materials on their website with some of these materials. And outside of nursing, there's two major bodies which set standards for nursing education. One is, anyway, National League for Nursing being one of them. National League for Nursing is more known for standards in the community colleges, the 2-year institutions. They do work with many of the 4-year institutions, but those are mainly with the AACN. In any case, they're working with National League for Nursing to get some of these materials onto its website. Next slide. The other thing that was a major activity for us was a scoping review of literature, which was centered in our Measurement Action Network, team from Rush and then from University of Minnesota. I think we thought it was going to take us a year. That was really a major effort. There's a manuscript in review. I know we just sent back minor revisions, so we're hoping that we'll get a decision soon. And we had to examine the state of practice in the education and training of healthcare professionals in the health and healthcare of people with intellectual disabilities. So hopefully that'll coming out soon. Next slide. So we're now in what we call phase 3, which is dissemination. We're trying to make this suite of materials available. Since the materials and experiences we've developed have all now been developed and piloted. And we're also attempting to promote programs that are similar. So if you look at the our website, IDD Health Equity, under resources, it talks about, get the title of it. It's probably called Emerging Trends. So simulation experiences, there's also materials from University of Oklahoma, the same FAME program. There's some simulation with standardized patients with intellectual disabilities at UT, the University of Texas. So there's some materials there. So we're trying to find and promote programs that are similar, on the website. Anyway, here's some of the links to some of the things that are on the website. In any case, our aim is dissemination. I think at the time when we wrote the grant, we said we hoped to disseminate something to 35 institutions at the end of year 5. And I think we're really pretty proud of ourselves. We're already up into the 40s, and we're sort of at the beginning of year 4. So we're sort of ahead of where we thought we would be at the time we started. Next slide. So my next slide was thank you. And, feel free to contact me or through the website. We're very happy to talk with you about how you can take on some of the materials. These things are grant supported, so there are not fees associated with anything. Like I know we're working with one university with the IEL program, and I know the legal people are talking about it. There's some form that basically says, you're not going to go off. It's intellectual property. You're not going to claim it as your own. But, we'll provide the materials to you. We're not charging any money for it. It's like, feel free to reach out. Anyway, we're very happy to talk about how you could use these things in your own context.